Okay. Hello, everyone. Can you hear me? Can people hear me out there? In Zoom land? Great. Good morning from the United States. My name is Hunter Groinger. I'm a palliative care doctor in Washington, D.C. in the United States, and will be facilitating this session of ECHO today. I'm really excited to be back here. It's been a little while since I've joined this particular group. I've had the opportunity for several years now to also participate with Project ECHO in Bangladesh, where I had a chance to go teach and work in Bangladesh in the Rohingya refugee camps right before the pandemic started. And this has been a great experience to continue this teaching and engagement with people interested in interdisciplinary palliative care like you all. We have two excellent speakers today. I'm excited to introduce both of them. Dr. Jessi Humphreys is a palliative care physician in San Francisco, California, in the United States. And I believe that she presented a couple weeks ago. So some of you or all of you may be familiar with her work already. And then Annalice Otoro is a palliative care nurse who will present our case for discussion today. And it's really great to have her engaged. I think I learned earlier from Aaron that Annalice, that you were involved in the learning side of this Project ECHO recently, and it's great to have you now as one of the faculty today. Just a couple of quick announcements before we start. One is that at the end of the session, please make sure to record your attendance on the Google Doc as you normally do. That's really important. And next week, instead of having the session 1 week from today, we're going to take a break in light of the different holidays that are happening right now. I think those are all the announcements. Aaron, if I missed anything, jump in. Otherwise, I think we'll go ahead and move forward.
No, it's great. Just if you want to introduce yourself, you can do that on the chat for now, and we'll go into the teaching session. Thanks, everyone.
Wonderful. Thank you, everyone, for having me. Let me go ahead and share my screen. Jessi, Dr. Humphreys, you met me a couple weeks ago. We were talking about trauma and a lot of trauma-informed care approaches. And I am happy to be back to be speaking today on really a parallel and related topic. I know you guys we've already talked about in this course a lot of the importance of many different members, and this has really kind of fed into all different topics up until now, and really the focus of palliative care being on whole person care. And today we're going to really focus on some really important elements of that. One is spirituality in palliative care, and the next is grief and bereavement, but really a broad interdisciplinary approach to support to patients and families. So we've certainly talked about this many times, that palliative care, as we have certainly talked about already, is pain and symptom management, sort of thinking about the physical aspect of suffering, and also psychological support, as well as the social and spiritual support. So I think we know this, but today we're going to think a little bit about how to put this into practice and some tools to use to think about how to screen and start intervening on these areas. And very importantly, also the care being really not just for patients, but for families, really critical when we think about bereavement as a piece of the entire continuum of palliative care. So there's been lots of talk about the psychosocial assessment, social history. I think classically in medical practice, we often think about this social history as being checking off some boxes of things we ask about tobacco, substance use history, and we really miss a lot of elements. I think this quote from Dr. Lewis of, "I'm tired of learning who my patients really were by reading their obituaries and attending their funerals," and wanting to know more about people as people, sort of in their families, in their cultures, in their experiences. And that being really a rare, actually, thing that we focus on in palliative care in comparison to lots of areas of medicine, but that is so important to providing whole person care. So psychosocial assessment, we're going to talk a little bit about that today and some questions to ask, just to put in your toolbox. But this is an interesting study that was really looking at hospice assessments. But, we haven't really thought as much about, in the literature, we're still working on this for sure, but what are sort of all the pieces that should go into these assessments? There's actually, a fair bit of debate about what the elements are. And I don't think we have necessarily today an answer of these 10 things or these 5 things, but more of an important highlighting of thinking about people as whole people and adding in other questions into your psychosocial assessment. So in this particular study, lots of the assessments for hospice assessments didn't include things that you might think are important, like functional status or preferences for treatment and care, awareness, understanding of their prognosis or situation, the disease progression. A lot of that sort of knowledge about what is to come in the future was not necessarily an assessment of people's understanding of that, was not included. People's goals and wishes around the type of communication they receive, around the way that they want to hear information, and people's cultural values. Those were all things that did not necessarily make it into those assessments. This is really, I think if there's one question that you can add in, you can try, and I use this not for everyone, but for some people, I find this really resonates. And I think one of the take homes of all of these extra questions you can add in are that they won't all work for all patients, but to have a toolbox of them so you can try out some with some patients. This patient dignity question has been sort of highlighted in a number of different areas, but this concept of dignity therapy, which really just means treating individuals as individuals and trying to treat everyone with dignity and trying to humanize people through the entire process of serious illness and dying. Patient dignity question is really a simple, open-ended question that says, what do I need to know about you as a person to give you the best care possible? There are so many other questions. We'll talk about some examples. Oftentimes, if that one, people don't fully understand what you mean by that, I'll follow that up with things like, what brings you joy? What makes you happy in life? Tell me about a really good day. What would that look like? Tell me a little bit about yourself as a person. Tell me about your family. But that individual question, what do I need to know about you as a person to give you the best care possible, is an interesting place to start for many people. So we're going to talk a little bit today about the concept of total suffering, which I believe we've sort of gotten to before, but to really kind of dive into a couple of the areas here. The concept of total suffering, as I think most of you know, is the idea that suffering is not just physical, right? And I think a lot of palliative medicine has become sort of overly focused on the morphine, which is important. It is critical, and oftentimes getting access to that and getting legalization of that is an incredibly important focus of a lot of our energy, because it is so important to people's total suffering. And there are also other elements that really impact not just people's overall experience of health, but actually their feeling of pain, right? So people's emotional state, people's social situation, people's spiritual suffering actually can increase their physical pain, their experience of physical pain, right? People really can feel like they have more physical pain because of these other elements of suffering. And our intervention cannot be morphine, right? For existential suffering, for emotional suffering. So we need to think about how to recognize and also intervene on all these different categories. There's been a lot written about the concept of sitting with suffering. And I'm going to talk about that today. It is probably one of the most core things that I certainly do in palliative medicine. And I think one of the hardest things that we do in palliative medicine, which is not the fixing of all problems, but the sitting with suffering. So suffering is often intrinsic to the end of life. I don't think that's a surprise to anyone here. But I think it's a hard thing for us to think about and to stomach sometimes, that there's often no way to separate suffering from the end of life, often from the entire continuum of serious illness. There's so many elements, death anxiety, there's lots of loss and grief, both before there's anticipatory grief and loss and the expectation of loss. There's the worries around feeling like a burden. There's the incredible worries for family, for leaving people's children behind, for leaving people's families behind, the isolation, the loneliness, even if you're surrounded by people, you're still lonely in the experience of being the individual who's dying. And this is really not possible to separate from the experience of dying. So we're going to talk briefly about a patient narrative, and we'll certainly do some, another case later. But one particular example here probably rings familiar for many of us: a 45-year-old woman with metastatic ovarian cancer admitted to the hospital with a bowel obstruction, who probably has weeks to live. And she has 2 children, aged 13 and 14. And the nurse reports she's been crying a lot, and she's worried about her children. She's asked for social work and chaplain help. I want you to sort of keep this case in your mind as we're kind of walking through these elements. So first, when you're going to see her, right, she's crying in pain, but crying overnight, really thinking about there being many different aspects that are impacting her experience of suffering at this point in time, and trying to step back and take a really broad, whole person psychological distress assessment approach. So some of the questions to put in your toolbox, this is a good one to kind of like copy and keep and try out some of them in the future. A couple that can be really helpful are: what are you hoping for? What are you worried about? Trying to get at people's emotional state. How are your spirits is one I use a lot. How are you feeling? What brings you joy? What brings you meaning? That can land with some people. For some people, that's a little bit harder to understand. What helps you cope? And I think actually what helps you cope is a really important component to think about. How have people gotten through hard things in the past? And that's a lot of what we want to be thinking about. One of the realities of the process of being seriously ill and the process of dying is that it's hard to intervene on, for example, severe depression when you have weeks left. It's hard to intervene upon a lot of the psychological distress elements. But one of the key approaches is trying to pull from what people have used in the past to get through hard times. So I will often say, what has helped you get through hard times in the past? It's a lot of how I phrase it for people. Some of the principles to think about in really assessing and providing psychological support is communication strategies around being non-judgmental, having a present emotional support. Validating emotions is probably one of the number one most important things to do. So when you're hearing emotions, hearing those emotions, naming those emotions, right? I can't imagine how scary this is for you. It's really common to feel sad, right? Even just normalizing that these emotions are normal, that they are okay, that they are intrinsic to this experience. And really importantly, and we'll echo this a number of other times, not trying to fix the emotions, not trying to wipe them away, not trying to talk people out of their emotions. So many people feel like they don't have a right to their emotions, right? They feel that they shouldn't have those emotions. They feel that they should be sort of wiping them away. And I think letting people feel that they can and it's reasonable to have the emotions they have is really huge. Certainly managing physical symptoms is important. So while morphine is not the solution to everything, it's very hard for people to think about all of the other elements of their whole life and their psychological needs if they're in physical pain. So that is a really critical component to manage, to think about some of the emotional, to get to some of the emotional processing elements. And then encouraging, as we mentioned before, what has worked in the past to help you? And again, the way that I often say it is, what have you turned to before during hard times. Certainly thinking about counseling, longer term counseling, self-care, and very much so longer term counseling if people have the time and the prognosis for that, which not everyone does. I think we often sort of turn to in palliative care the individual in terms of our thinking about, do they understand their prognosis? Do they understand what's going on? But it's actually really important to think about the unit of care is usually, not for everyone, but usually the family. And at least to be curious about who the unit of care is, right? It may be different. It certainly is different in different areas. But knowing that illness impacts friends and family, and that patients feel the suffering that is impacting their friends and family. So without acknowledging that aspect of it, we're sort of missing a piece of suffering that's landing on our patients. I don't think this is a surprise to anyone, but just the impact of illness on finances, on income, on the education, of one's children, on who is now becoming a caregiver is all really critical to people's experience. And families need a lot of things, right? So families need information, what to expect in the future, that anticipatory guidance, which is so critical for helping people plan, for helping people think about the future, especially for families who, the families will be there after our patients have passed potentially, and helping people set up their plan and make decisions around what is to come. Certainly emotional support. So thinking about the caregiving role and knowing that there's a lot of challenges in that. Thinking about legacy work, which is really a way to provide patients or individuals who are dying a way to leave something behind. Sometimes this is stories, sometimes it's something produced, sometimes it's just something that is important to be said to people and their family. And then thinking about the grief and bereavement support really after someone has passed. And then practical support, right? There's all of the pieces that we've already talked a little bit about: pain management and nursing care and medication counseling. And sometimes practical support means thinking about financial support or education support or even food access for people. So that really being a critical element in the overall social support approach. A brief comment here. This is not really a talk to focus on a full assessment and treatment of depression and anxiety, but just to say that these do happen, these clinical diagnoses, which are distinct from the general anxiety, the general fear of death. There's really a distinct clinical diagnosis of depression and anxiety. Very reasonable to think about medications, noting that especially for depression, a lot of the SSRIs that we start with, there's some examples of doses and some options here, do take some time to work and take some time to increase. Oftentimes the first line dose doesn't work, and so you have to go up. So recognizing that is very much an option, and also sometimes not necessarily possible depending on someone's length of life. Anxiety, just highlighting there, similarly also can intervene with SSRIs or benzodiazepines if time is shorter, which we often absolutely do. One thing I think is helpful to talk about and to think about is that we often think about this difference between depression and demoralization, and they can look very similar. So depression is really a clinical diagnosis characterized by signs and symptoms, many of which are on the right. You probably recognize, right? Feelings of sadness, loss of interest in things they're doing, guilt, often changes of energy, changes of appetite, either up or down, difficulty thinking, oftentimes trouble sleeping too much, sleeping too little, and has sort of a set of clinical criteria to diagnose. Certainly higher risk of mental illness, isolation, hiding emotions. Demoralization is not necessarily depression. It's often mistaken for depression, but there's situational and characterized by a lack of motivation around specific, often situation, often diagnosis, or often a sharing of information about people's prognosis. But it can look a lot like depression, but it's usually more related to that specific situation. And that oftentimes demoralization can improve over time. It's not as responsive to medication. there is some debate in the field about these diagnoses and the crossover here and whether, how exactly they should be treated. But I think what's important is demoralization often does not necessarily respond to medication as much. And a lot of this psychosocial assessment, emotional support is going to be really the focal and really critical component, really in both, but in particular in demoralization. So I want to talk a little bit about spiritual distress. Oftentimes we also call this existential distress. And I want to highlight that oftentimes this is related to people's faith beliefs and their religions, but not necessarily. And so kind of broadly define spiritual well-being to be understood as a feeling of peace. And spiritual distress can occur when people are unable to find sources of meaning, hope, love, peace, comfort, strength, and connection in their life. This distress, as we've talked about, is really interwoven, connected to people's physical and mental health. And terminal illness can trigger a lot of existential distress, right? People's questioning of what is my meaning in life? What is my connection to people in life? Where is my strength? Where is my comfort? And it can also really be present in friends and family. One assessment we wanted to propose, there's a number of them, but one spiritual assessment tool is the HOPE assessment. And again, this is to really just give you tools to put in your toolbox, questions you can ask, things you can try out to try to further understand a person and their family. So the HOPE assessment has just a couple of things to potentially run through. One is asking people, what are your sources of hope? What gives you hope is how I would phrase that. Or what gives you meaning? What gives you strength? What gives you that sense of peace? When do you feel most at peace? When do you feel loved and connected? Are you part of an organized religion? Certainly helpful to know about, especially because pulling from that religion and having faith support individuals is often really a critical intervention. Do you have spiritual practices which can help you? And how is your, potentially spiritual suffering, how is that affecting medical care and treatment? When you're doing a spiritual assessment and you're thinking about spiritual support, really critical to listen to people's story and show compassion. This is the hardest thing, but not giving answers or advice, not imposing one's own belief. So really critical, especially if people's religious beliefs may differ, not providing, that fix, not trying to say, your interpretation of what you think has happened, right? Not trying to sort of help them see, what God's role is in their life or why this has happened, right? And really letting them experience what they're experiencing and have their own thoughts and feelings about it. Using prompts instead, like, tell me more about that, or what does that feel like for you, or how do you know when you feel better? Really trying to avoid that reassurance that people talk about death and dying. Very many people believe in heaven and an afterlife, and that may provide a lot of comfort. And some people may be questioning and struggling with that and feeling fear around that, and really trying to sort of reassure and say, you're going to be fine.
Hey, Jessi, you went on mute.
That's so strange. Okay.
There you go. Okay.
It just auto muted me. Really trying to avoid that false reassurance, right? Trying to avoid the reassurance and trying to talk people out of their feelings, because that has basically never worked since the dawn of human existence. Meaning can really be found in so many different areas too, certainly in organized religion, very much in support for religious or spiritual leaders, incredibly critical. And also meaning can be found through interactions with friends and family and lots of creative activities too. And I think most humans feel supported and reassured to know that they're not crazy in their feelings, right? And that they are not alone, that many people struggling with life-limiting illnesses feel similar feelings. Last thing we're really going to talk about today is grief. And probably a number of you have seen these stages of grief: denial, anger, bargaining, depression, acceptance. Elizabeth Kubler-Ross is famous for sort of talking about these. and David Kessler as well, and other writers. I did want to point out, and Elizabeth Kubler-Ross was always very distraught to sort of hear how people talked about the stages as things you go through, right? You do one and then you move to the next one and then you do the next one. Here, I'll move back to this one. You go through denial first and then you go through anger and you go through bargaining. And she had never written about the stages of grief to be like that, right? She had never intended anyone to believe that you go through one stage and then you go through another and then you go through another. That was never the intention, but that was sort of what got taken away in public writing. Some people have said, oh, it's more of a cycle, you go from one to the next, but then you kind of go back again, right? You're not necessarily just going through all of them and then you're done. That's not really how it works. And I think this is actually one of the images I like the best, right? That we sort of, it has been mispresented as this process of starting in denial, going to anger, ending up in acceptance, right? And the road you actually got is sort of a little bit crazy. And I will say sort of has elements of acceptance, then sort of loops back on itself as well. If there's sort of one slide you take away, this would be the one that I would think about today. And, importantly, there's been some writing by David Kessler after Elizabeth Kubler-Ross about a sixth stage of grief, which is finding meaning after a horrible, tragic loss. But I think it's just really, really critical to appreciate that there is not one way to grieve. There is not one pathway. There is not one goal to get to acceptance, right? There's not one goal to get to meaning making. Grief does not travel on a predictable path. It doesn't disappear. So our goal is not to get rid of it for people, right? It just changes, right? The nature of grief is that it is lifelong for the people who are left, and it is different over time, right? And you can have elements of all of those components forever. And our job is not to fix grief, right? Our job is to walk with people through their grief, to really think about the sitting with suffering, right? The being present in it without the fixing. And that is a really rare thing. People who are in deep, deep suffering, everyone is either running from it, right? Not trying to ask questions about it, trying to hide from it, or trying to make it better, right? That is the natural thing people try to fix. And it is a rare, rare job, and I think our job in palliative medicine often to really sit with people in their grief and sit with people in their suffering, right? Even in situations where we feel like, there's things that we wish we could do differently or that we wish we could support, and also knowing that that might not be possible, and how to just show up and be present, which is in and of itself a huge gift to provide to people. So in summary, psychological distress and really this whole person suffering is common for patients facing a life-threatening illness. And we in palliative care can really provide support in a lot of different areas, right? Thinking about that total suffering and the information and guidance about what's to come, the emotional support and assessment, and some of the practical interventions as well. Really important to think about spiritual distress as impacting people's physical and mental well-being, thinking about what provides people meaning, what has helped them get through hard times before, listening and letting patients and family members identify what helps them in difficult times can help to really pull from those strengths they've used before. And then really thinking one of the hardest pieces is there's no one way to grieve, and our job is to sit with that suffering and to walk with people without necessarily fixing. Some references. Thank you so much. I'll stop sharing now.
Thanks, Dr. Jessi. I'm looking in the chat to sort of monitor for any questions or comments that people might have. A lot of thanks to you, a lot of notes that these are really good reminders for all the care that we do and a lot of what we need to be doing better in our field and in all medical fields. If does anyone have any questions or comments? If you do, you can certainly put them in the chat. we'll take a few minutes to do that. And/or you can come off mute and just ask Dr. Jessi directly.
Dr. Jessi, I know there was one of our participants. Her name is Patience. She just joined the call. She's one of our clinical officers out at the coast. So it's a fairly limited resource area. It's not necessarily a humanitarian area, but she recently had a very difficult case, and it almost felt like the family wasn't grieving, or they had grieved a long time ago. What do we do in those situations where families, maybe because they live separated or live quite far away, how do we support a patient or even a family that, where that grief either had already happened because they anticipated the loss and they processed it and are not really interested in talking? Or, how do we support people during those kind of more complex situations?
That is such a great and hard question. I think I'm hearing a couple of questions embedded in that, which is when you're taking care of a family that may not seem to be grieving, right? Just even that, and may seem, whether that's calm or whether that's they're not expressing what we might expect as grief, right? They're not expressing sadness, not expressing anger, some of those things that we often see. And I want to say that can be a couple things, right? Sometimes how people express grief is by not expressing an emotion, right? Oftentimes, and many of us are taught to keep our emotions quiet for a variety of different reasons. So sometimes people can seem calm or people can seem fine, and that can still be covering up an immense amount of emotion. So I want to highlight that and sometimes people can feel a mixture of emotions and feel sort of confused about that. And then I would say one of the interventions is to just sit with that again and to normalize, right? To also say, some people may be feeling numb. Some people may not be feeling anything, and that is really common and normal. So letting people know that they aren't crazy, they aren't awful people for sort of having that expression of grief too. That would be one thing I would think about. And then I think really separately, and Erin, this may have been the case you're bringing up here, many people have grieved a lot before someone's actual death, right? That's actually not uncommon at all, especially with long illnesses. Now, this could be because they were separated physically, and that happens. People have sort of grieved the separation, and then they may be elsewhere, and in their minds, the person has kind of passed already. We see this a lot with some long diseases, especially with neurological diseases. We see it a lot with cognitive impairment, like dementia, where people are sort of slowly losing who they are as people, and people are grieving that over time. And then really some of the feelings that people can have at the end when people die are relief. Our relief or joy that this person has actually finally been released from this long suffering experience. And that is a really hard feeling to sit with, because a lot of people feel very guilty about feeling happy that this person has died, but in reality, what they've really done is grieved over a long period of time. It's not that grief is any sort of less real or less fair or bad in any way. It's just a different process of grief. And sometimes that's just for us to kind of sit with, right? That people may have gone through that process already in their own way and be in a different state now. I don't know if anyone else has any thoughts about that.
Thanks. I think that's really helpful to hear. I think those are some really insightful comments. It can be very complicated, especially with those long trajectories that you're describing. I see that a request about just sharing some tools to assess depression, spirituality, anger, and grief, and how to interpret them. I don't know. It's a lot of tools out there. But I wonder if there are any sort of that you'd like to highlight for folks here, or references we can send people to.
Yeah, it's a great question. I know we talked for spirituality in particular, we talked about the hope assessment to get a sense of people's sort of state, but didn't talk about spirituality, anger, I'm guessing that means sort of more the existential suffering. I think for that, generally using some of the questions we talked about in this presentation around what gives you meaning, what gives you purpose, what helps you feel joy, kind of getting a full understanding of the whole person. And then asking some of those hope questions of, is there an organized religion? Is there something that provides you hope or happiness or connection? And then for depression, absolutely, there are separate tools. I won't probably go into them in detail today, but there's a bunch of mnemonics you could think about, and I'm sure Aaron could probably send out some of them too. Siggy Caps is like a classic, but really it is, and I can go back to sharing my screen really quickly, but really it's nothing fancier than thinking about, here, I'll go back to the depression page. Here, this stuff on the right basically is a list of things. So a lot of the assessment tools have elements of this, and you kind of get points as you go through. So are people having constant sadness? Are people having, anhedonia? We talk about like loss of interest in things. Are people having problems sleeping? People having appetite changes? Are they having fatigue? Are they feeling foggy? Are they feeling guilty? And those things usually just add up. So it's usually assessment tools to think about kind of all of those elements.
That's great. And I see one comment I just wanted to highlight from I'm reading Esther Beatty. I've been in a culture where people believe that if one cries, like weeps, they're causing the deceased to suffer, which is a really interesting reflection about different cultural expressions of grief and suffering and interpretations of that. Something we should always be mindful of.
I think what's important to highlight there is just, and Esther, thank you for really bringing up so beautifully. It's just there's so many different ways that people present grief, right? There's some cultures that hire individuals to cry. Right. There's a whole entire practice of that in many places where people, actually hire individuals to come and grieve visibly. And that is actually a way to really honor the deceased as well. And then you're highlighting a completely different approach, right? Which is that this worry that crying might actually cause the bereaved to suffer. And I think just to honor that it's different everywhere. It's different everywhere. And I try to also respect people's cultures always, absolutely, and learn more about them with curiosity, and to normalize people's individual experiences, right? That can be someone's sort of culture and belief. And if someone is feeling like they want to cry or they're sad in private with me as I'm seeing them, to kind of normalize those feelings and say many people, feel this inside them. And that's sort of my job, to normalize what they are feeling inside them.
That's great. Thanks so much. I think we can, keep questions and comments going in the chat, but I want to be mindful of time. And so I think I will shift over to Annalice, who will present our case.
Annalice, can you see the screen?
It's a bit tiny.
It's too small. Okay, maybe wait a minute.
Maybe also the slides, you can hide the slide.
Did it come through now? Yeah.
No, yeah, it's
Annalice, are you okay? There might be a little bit of a delay.
Yes, I'm sorry that I had the network problem.
Okay, no problem.
As we can see, okay, as we go through the case, we need to reflect on the questions that what emotions are you experiencing? That's we going to experiencing. What the caregiver, what will you explore more about the patient's emotion? How can you help manage sufferings? Okay, next hearing. Okay, our presentation case today is about a 32-year female diagnosed of carcinoma of the body or the body parts.
Your internet is cutting out a little bit, Annalice. I wonder if you,
Okay,
can you go to another part of the room?
let me see. Okay, Erin.
Yeah,
So
that's very clear.
we
Yeah,
have
go ahead.
okay. Now on examining the patient, we have to rate our patient. We give her the scale, the score, assessment score, and then we found that the patient had a severe abdominal pain and back pain. Pain scale was 8/9. Last bowel movement was 10 days ago. And then severe vomiting and nausea. This is a patient who is going into intestinal obstruction. Next. The patient psychosocial and family concerns was especially for the son, 4 years old, who is crying, who is often anxious, cries a lot. The husband is not there with her, has not come to visit her since the diagnosis. Grandmother is taking care of her young child. Her brother stays with her in the hospital. And then she becomes restless and crying, screaming out. As we go through this, assessing the patient's psychological and spiritual issues, we have to put in mind what we have learned about the stages of grief and the 4 stages of grief that we have gone through. The anger, the depression, the acceptance, the bargaining, and the anxiety. All of them, we have to know how the patient has gone through. You see, she's crying, she's screaming, the child is anxious, cries also a lot. She's really totally in pain. This patient is in total pain that we need to address. And then the spiritual part of her life entails about all the other 3, the physical, after the diagnosis, the emotional, the psychological, the social. The husband is not there. You see, she can fail to have her spiritual stability. She may have questions such as, next, Erin. Now, after all the concerns about the psychosocial and the physical concern. She asks herself so many questions, so often, why me? Those are some of the questions that our patients ask themselves when they have the spiritual suffering symptoms. Why God is doing this to me? Why my family? Then she states, I'm scared to die. Tell me more. What are you most worried? When you're asking the patient to tell you more, and this patient already has told you she's scared of dying, now this is when we employ the communication measures, the skills that we have learned about communication in the previous lessons. We have to visit the family. When the family visit the hospital the first time, what information did the family receive about the diagnosis and her prognosis? Then they were informed about lack of treatment options in the refugee camp. Actually, in the humanitarian settings, especially the refugee camps, you fail to find management for cancer patients. The referral system is very difficult, and then you find patients just give up. They keep asking questions, why me? Why God is doing this to me? Why my family? Why not another one? Now that is the bargaining part of it. Why only my family? Then now, such a patients, we need really to give them psychosocial, spiritual support. We need to involve the multidisciplinary team working together with the spiritual leaders to give them that moral support. Then to reduce just suffering, we need to have the clinical part team. The clinicians have to be there for her to give us the pain relievers. The nurse has to take care of all other needs. This patient has not gone for long haul or reopening bowels for 10 days. What do you do to relieve such a symptom that will give her at least some peace? Next, Erin. The patient was well 1 year ago. In summary of the case, after diagnosis, she did surgery but could not complete further treatment due to lack of access. You see, once the patient is referred from the refugee camp for specialized care somewhere, next visit is very complicated. It will be difficult. Once the diagnosis have been reached and it is found that it's terminal illness, it becomes again another issue for such a patient to move out of the refugee camp for another interventions. So she's now receiving just palliative care to complaints of severe pain and vomiting. Then she is also having severe spiritual concern. That's now she's asking, why me? Why did God allow this to happen to me? She received counseling from the team. When you are working together as a multidisciplinary team, it becomes sometimes easier to handle or manage such a patients or such a cases. So in grief, some people grieve even before the really event happens. She's grieving before death occurs because she's imagining of what she did not maybe complete, what she intended to complete but she did not complete, what she will leave behind, what her family will look like, her child who is crying, who is anxious. She's not aware whether the husband, the father of the child, will come back to take care of the child. All this, then involving the psychologist is a very important issue in such a case, and the spiritual leader to take care of such a needs of such a patient. Next, Erin, if there isn't, then we can go back to our questions and then we answer our questions. Thank you.
Thanks, Annalice, so much. So as we begin to reflect on this case that Annalice has shared, these are some of the questions that we want to put to the group. So as a healthcare provider, what emotions are you experiencing? I think we've identified that these serious situations can really affect us as providers. What might you further explore about the patient's emotions? She shared some very serious and very real emotions in the case when it was shared, and then how can you help manage the suffering? So maybe we'll start with the first one. If you want to put in the chat, what emotions are you experiencing when you hear this story? Or if you wanted to picture yourself as one of the providers that was assessing this patient. What are some of the emotions that you feel? I know Dr. Jessi was talking a lot during the session that we need to acknowledge patients' feelings. We can't tell people not to feel certain ways. I think this is also really important, even as providers, to learn how to put words to the emotions that we're experiencing. Annalice, what are some of the emotions that you experience? I know Annalice and I are quite good friends, and she often will share about difficult situations or difficult cases. What are some emotions that you feel?
Thank you, Erin. Okay, sometimes I found myself helpless. I find myself hopeless. I get angry. I even sometimes withdraw from the social network sometimes, because when you get a patient who is really suffering like this one.
Yeah, we can actually take it not personally that we've caused the person to be sick, but we take these situations very seriously. As healthcare providers, we want to help people. We want to see people recover, right? So we may also go through some spiritual distress as well as a provider. Dr. Jessi, what are some emotions that you feel when you're working in these really hard situations?
Yeah, it's a great point, and it's so critical to think about this, because it's real. It's part of our we grieve as well with patients, and I think a lot for me, the cases that are the hardest, that I feel the most, are ones that make me think of myself or my children or my sister or my mother, and I feel like a deep sense of fear, because I often am thinking about, what if this happened to me, or what if I was dying and leaving my children, and just frustration, so much rage and anger at systems and challenges and lack of access for various people for various reasons, but also just the unfairness of it. Like, I just feel like the unfairness that nothing is guaranteed in our lives, and the universe is not known, and things can happen. And then I think just a deep sadness too, like an anguish at thinking about being in a situation or leaving my children, or seeing someone leave their children or leave their family members.
Annalice, what are some of the emotions that your colleagues feel? Of course, Dr. Jessi, myself, a few of the people on this call today have had experience with palliative care. So we also learn how to, we know how to share our emotions a little bit better, I think, than an average person that hasn't had this type of training. What do you find your colleagues say, or how do they interact with this patient? Because I know you're just one on your team. How do your colleagues?
Sometimes I will hear some I feel so frustrated. I feel so exhausted. I don't know what next will happen.
Yeah.
Some also bring in their past experience and they say, now, if this can happen to such, I think I also have gone through this, but I didn't know how to solve it. So, yeah.
Okay. I think it's really important, especially in these kinds of cases, that we offer time and space for our colleagues to share. Of course, we are quite busy, and I know, Annalice, your team is extremely busy. You're short-staffed, and you have a lot of people suffering in your setting. But it is really important that we allow our colleagues also to share their emotions. A lot of good things came through on the chat: feeling hopeless, unable to get care, feeling anxious, compassion. At the same time, trying not to feel or take on a patient's pain. I think this is something that we often do to help us not burn out, is to feel compassion, yet also to be careful that we don't physically take on the pain of our patients, feeling discouraged, hopeless. Really, really important for us to also name our own emotions. So as we go to the next question, what might you further explore about the patient's emotions? So Annalice shared about the patient's emotions and her spiritual distress. What are some things that you might like to further explore? So sometimes when we first ask a patient how they're doing, they answer, and then we ask a next question or leading them to expand on what they're sharing. What would you do? You can put it in the chat. I can go back to the slide where we were talking about the different symptoms. Most of it was related to here, some of her spiritual concerns. What would you want to further explore or better understand? I know Esther is one of our nurses, one of our nurse faculty. She's in Senegal right now. Esther, do you have any thoughts?
I think this area is one reason why we really need to train spiritual leaders. One is so different, and it's hard for us to ask certain questions that we know are okay to ask. So I think targeting spiritual leaders, like I know in Senegal, we've done some training with imams and pastors, because often if they're not okay with this whole thing and they tell people, oh, just trust God, you should feel that way, because that's what I see often. Just trust God, and this is just the way it is, and if you have faith, you're not going to feel sad about it. You're just going to accept it.
Yeah, it's a bit tricky because I think for so long, possibly before someone had a very serious illness or a chronic illness such as cancer, that may have been a very strong belief that people had, that the stronger their faith is, the more blessings they'll receive, or the more help they will receive. And I think that's something that slowly, as we work with people for lay persons such as a pastor who's not a medical professional, to better understand chronic illness and suffering, to be able to better provide support for people in a way that doesn't undermine someone's faith, but also doesn't give that false assurance that Dr. Jessi was talking about. Someone mentioned in the chat, spirituality in palliative care versus customs, taboos, and beliefs play a big role in this person's facility. A lot of people are asking more questions to address someone's spirituality. Oftentimes that's also their beliefs and their customs. And this is not something that I think we are enabled to change. We can't change someone's belief or their custom, but we can help them better understand what they believe, so that the actual spiritual distress that they have, they can deal with. So for example, if you take care of someone that's even from a different religion or a different belief that you can help them process what's happening in their own worldview, in their own way, and yeah, do your best to refer to someone that can speak with them. Maybe prayer is really important. And that's an area that you've come to know because they've shared that, and you can encourage them to do that.
I was wondering,
Annalice,
Erin,
what-
if I can ask
yeah.
a question for people to answer in the chat.
Yeah, so what do people, what are some other questions you would ask someone if they were starting to say, why me? Why is God doing this to me? Would you avoid it because it's a bit of an awkward question? Would you say also, I don't know, why are you sick? How do we talk to people when they start talking like this? Annalice, what do you do?
For us, I think for us, we have been a bit relieved on that place because whenever there is a patient so serious with a life-ending condition,
Yeah.
the relatives always will bring in a spiritual leader. And
Okay.
the spiritual leader will take care of the patient until the end. So most of the time we are relieved of that part.
Which is okay,
But
because it's also,
I think Erin employing the model of what Jessica wrote, what she did, what she taught us about hope.
yeah.
When we ask the question surrounding the hope model, will assist us to get more information about the patient's spiritual need.
Yeah, and we could share that again. I think just like if you've never assessed someone for pain, and now that you have a new skill and a new tool and you've used it a few times, you will be more confident and you'll be less nervous to ask someone, because sometimes when we do assess somebody, we actually realize that there is something that we can do. There, maybe you've never asked someone about pain, and then you begin to ask, and then you realize their pain is uncontrolled. So now you have to do something about that. When it comes to this spirituality and distress and very serious psychological symptoms, sometimes we're a little bit nervous because we don't know what the next step could be. But as you have more confidence, and I remind you every week, we are here together with you. We are a team. If you have someone that's experiencing serious distress like this, we do want you to try to use some of the new tools that you've had, and know that you're not alone. Something might come up that you're not ready to deal with. Maybe you're not so confident to know how to support someone. That's why we're a team. That's why Annalice said, even, they may have identified that someone was in a lot of distress, and they let the family know that they really should bring someone in that can support them as well. I think it's really important that we don't ignore these signs when someone is suffering. I think that's really important. And we'll move. Am I missing anything in the chat? You reassure your patient. Yeah. It's important. I know, Tawana, you're one of our more senior palliative care nurses. Did you want to unmute and explain a little bit? What would you say, or how would you reassure them? Mohammed is working with MSF in a home-based palliative care program in the refugee camp here in Kenya. Did you want to unmute? Reassuring patients is really, really important. We just need to be aware that when we reassure people, we are not giving that false reassurance. If we know that a patient's prognosis is poor, And if we know that a patient is declining, we can sit with them when they say that they are scared. This is Dr. Jessi has shared, and maybe from your other palliative care training. In this situation, you don't want to say you will not die, because we know that that is not true. We know, to the best of our medical knowledge and our nursing knowledge, that a patient with a very poor prognosis at the end of their life may be thinking some things about death. They might be thinking things that are very difficult. And if we say you will not die, or don't think that, or let's talk about something else, we might be missing an opportunity to support them. And it isn't easy, and there probably will be times you don't know what to say. But even sitting in silence with someone, even for a few minutes, is therapeutic. Touching their hand, of course, we have to be careful with COVID, but some of those risks are less now. Being in the presence of a patient that is suffering in this way is very important. Sometimes you can turn questions back to patients. So if the patient says, why is God doing this to me and my family? You could put the question back and say, why do you think God is doing this? Just to engage in a conversation if you're not sure what to say. Or tell me more about what makes you worry. You do need to set aside time for these kinds of interactions, and you don't want to rush them. But if you have a patient that's an inpatient, chances are you may know that someone is quite worried. So you can set aside time maybe in the afternoon or during a quieter time. Or if you're doing home visits, you can make sure that you have an extended amount of time if you know a patient is experiencing these symptoms. Okay, and the last one, how can you help manage all of the suffering that this patient is experiencing? So we'll go to the summary. So she, after her diagnosis, she did surgery, but could not completely finish her treatment due to lack of access. She's receiving that palliative care. So she has the suffering or the symptoms of pain and vomiting, as well as severe spiritual concerns. So what can we do as you head out this week into your workplace, and you possibly are faced with a situation like this? What would be one thing, maybe you can write in the chat, what would be one thing that you would feel confident to do for this patient? It might be different for each person. All right, yeah, Esther says we need to work as a team for sure. So in this situation, we might think to gather a team. Maybe there needs to be someone that looks at her medication. Maybe we need to get the pharmacist and the social worker. In many of our refugee settings, in humanitarian settings, we don't have a lot of resources, but we sometimes have mental health care providers because trauma is such a big thing for our patients. Lamek, what is one thing you would do for this patient, just knowing your background?
I think we need to work together as a team in the hospital so that we make the patient have hope of coming back to life, because some of them might believe that they're dying, but working together and bringing spiritual leader to help in a situation where the patient is living in self-denial of dying. So we need to work together and bring the person to life.
So I kind of agree with you, Lamek. I think though in this situation, if we focus on life, we might be avoiding a difficult conversation. I don't know. What do you think, Dr. Jessi?
Well, I was wondering, by Lamek, what do you mean by bring back to life? Tell me more.
Okay, I mean that the patient might think that he or she is dying, and even he or she cannot believe you what you are saying. But because he's dying, and also the symptom may not be able to manage. Maybe the patient is in the stage 4, suffering cancer stage 4. But now the patient is something like is hospitalized, maybe taking about 1 month, 2 months. So the patient will not be able to believe you. So it's good to work as a team and also to bring spiritual leaders to help in emotional issues. That's why I'm saying bring back to life.
Yeah. No, it's a good point. It's because of course there's many ways to die. There's the your body dying, but there's a lot of maybe they have a lot of symptoms, and maybe they have 1 to 2 months left, and you can have more experience or enjoyment of that time if your symptoms are managed, right? And maybe that's what you mean by bringing back to life, like having some time. And that's absolutely what we're talking about, is how do we help people find their meaning or things that bring them joy in what time they have left, while not running away from the fact that they may still be dying, their body may be dying. But I think another thing I wasn't sure if you were meaning is lots of people have different views of what will happen after they die. Spiritually, and whether their spirits will live on, right? Or whether they'll be in heaven, or whether there'll be some sort of coming back to life in that. Everyone has different beliefs. So figuring out kind of, and like you said, really tapping into that team and those spiritual leaders and thinking about what that could look like too. That may be reassuring for some people in a spiritual religious belief where they feel like they'll live on. It may not be reassuring if people don't believe that, right? If people are telling them, don't worry, you'll live on, if they don't believe that. So really having their spiritual leaders help you with that and help support them, I think that's absolutely the right approach. Well, not hiding from the fact that they may be still dying.
Yeah, I think there's some good things coming through in the chat. Starting with physical symptoms. So this patient was sharing that she was in pain and she was also having vomiting. So identifying how we can manage those as we continue to address some of the other emotional issues that she's sharing, and then just helping her to find hope. So I know that many times in many cultures around the world, we hope for a cure from many of our patients. And this is for babies, for children, for teenagers, for adults, for elderly people. We do hope for a cure, that we can find a medicine or a surgery or something that will help someone be cured of the disease that they have. And sometimes, especially in palliative care, the type of patients we see, that hope changes through the trajectory of a chronic illness. So we don't necessarily deal with patients after a car accident because that's quite like instantaneous, right? It's a traumatic death. A lot of times the patients that get referred to our teams are patients that have been sick for a while, or they have a very serious sickness and they might have lots of symptoms, and that's what we want to help them with. So I think, as Esther was sharing, helping the person find hope. And it might be different for each person, and it might be different each month. It might be different now based on the fact that she is in pain and is vomiting. Maybe she's hopeful, and we can help her realize that maybe one of her hopes is to be in less pain. Maybe that's one thing we can do to help her find hope. I know we talked earlier in this course about pain assessment and pain management, how that's a huge part of our job. And many of our colleagues are not really confident to do that. So we need to step up and do that for our patients. Someone shared, support the patient with the little faith they have. Yes, we can definitely walk alongside them and identify what they have faith in and really encourage that. Calling spiritual leaders to come alongside them, having someone sit with them. This is Sometimes it's difficult for us to often do research on patients like this because it is a very critical and it's a crucial time, and it's a very private time even as someone is dying. But I do believe there has been research. I think Dr. Jessi, it's been from parents whose children have been dying, and just research around their grief and bereavement and some of the things that they really needed at the end of life for their child. And that one of those things was not to be alone, and finding ways to have someone with them. Maybe that is one of the providers from the hospital if the actual family caregiver needs to be somewhere else, but making sure we do something. And if that's a wish of someone not to be alone, that we do everything we can. It doesn't sound so medical, but it's really important. Annalice, do you want to share?
Yes, Erin.
Yeah.
Yes.
I wanted to say.
Yeah.
Okay. I wanted
Sorry.
to say that this is the patient that I will give more time in. I'll take more time with the patient. I'll stay with her
Right.
because maybe to relieve of the brother, she's worried the brother is getting tired. I'll be exchanging instead the husband is not coming, so I'll take over and stay with her. At least when she's screaming, I'll be able to comfort her and ask her more.
For sure. And there is a really inspiring quote that we often talk about in palliative care. And I think, Lamech, this is maybe what you were trying to share earlier, is to put more life into someone's days and not necessarily to prolong their life or not to put more days into their life. And I think we haven't talked about it so much, but we probably should. It's just talking about the quality of life that a patient has. So making sure that we treat their symptoms, we talk to them about what their wishes are, what their needs are, and finding ways to improve their quality of life. We may not be able to cure their disease. They might not even be able to be discharged home. But what can we do to improve their quality of life? Maybe there's an empty a bed that's by the window and the patient really wishes for, access to that sunlight or the breeze coming in from the window. Could we do that? Maybe it'd be a bit annoying or it'd be difficult to ask one patient to move, but we possibly could. Maybe the patient really enjoys a certain meal. Maybe we could talk to the kitchen and make sure that that meal is given on a regular basis to this particular patient if they're still eating. These are some small things, again, not super medical, but some small things that might focus on someone's life, right? The quality of their life. Does anyone have any final thoughts? We're getting close to the end. Yeah, Hassan?
Yeah, thank you very much. And when you meet such a scenario, you have to first of all sit with the person, the patient, and counseling every time. So you have to tell him that the person, the patient, he's not the only person who has come across such an issue like this. It will happen every time and every person. So you have to share. You have to tell the person these things. This from the side of God, and God will help you, and you will be okay. So every time, if you all the time, if you sit with him and tell him that will become good and it will become okay. So the patient will be taken, since that this person was, you are doing counseling him, he may think that this your brother or your sister, all the time he will tell you something. So maybe that person will take relief and he will become okay. So I personally, I will be if you meet such a scenario, you have to cancel every time, every morning, every time you give time that person. And also, if you are staying with a hospital, you should not discharge with him immediately, because this person, if you discharge him and take him back to the home, maybe he may not get support the way you support in the hospital. So I personally, I could say every time until the person become good. You will stay with the hospital, and you will tell him that this thing is will become will be okay. I personally I met such a scenario like that because I personally I used to work with the hospital in Degahley, the Dadaab refugee camp. So one of the I met a lady that her child sick and the heart. So she has taken several times in Nairobi. She was not getting any medication. She cried every time. I counsel her. I meet with her every time. Even I get her opportunity. I talk to the doctor, the main doctor. I told him that please, this kid, we have taken several times in the Nairobi. He is not getting any medication. So the doctors, they say that we don't have here in the doctor in the medication. So so we you have to get further medication in every, whether it's abroad or somewhere else in Europe. So later on, we refer that case to the UNHCR, and UNHCR they have taken they have given a settlement. Currently, the child is that sick, and the lady, they are in America right now. The guy is okay, he's become okay, and even he's driving right now. He's working because that kid. If you see that, and we have not cancelled, and we have not informed, give the right place, he may not be he may not be taken. He may not get a chance to get a life. So by the time we have given that opportunity, we have referred to the UNHCR. The UNHCR, they give a resettlement, and the mother, she has taken to the abroad. Right now, she is there in America, and the child is become okay. And the mother, she become okay. She communicates with me every time, and she appreciates me.
That's really nice. I think this is a really good topic to bring up, Hassan. I think we need to advocate for our patients. It's really important. If we think there's something that we can do to make their situation better, it's really good. Thank you for reminding us of that. One thing that I know, Hassan, this is some new information that you're learning, palliative care. One thing I want you to remember from today is that we do need to give realistic hope. And I think it's really important that we don't compare our patients. So one situation where someone, even with the same diagnosis, even very similar age, same sex, female, male, one person may die and one person may not. So I think we need to be very careful because of the role that we play as healthcare workers in society. We need to be very aware about how we interact with patients because we want them to trust us. So if we, of course, the word in English, good, or you're going to be okay, or you're going to be good, those are very simple words. But I think families do really trust what we say. So we just need to be very aware of that. And I think, Hassan, I'm really interested to work with you. I know that you interact with a lot of patients. There's a lot of suffering happening right now in Somalia. And there's many people that if they can access the right care, they may recover. But we know that there are a lot of patients that we do interact with that they won't. And that's not easy for us also as providers to continually interact with people that don't recover and that die. It's not easy. But I do want you to challenge yourself and just think and reflect on that today, that there may be situations where it may not be appropriate for you to say everything's going to be okay. Annalice, what do you do in those situations? And then we'll finish off for today. Annalice, what do you think?
Hi.
Hi, Hassan.
Yeah, the other things, by the time in the hospital, you may meet a lot of people have stress and depression or all things. So it's only need to be canceled, and all the time you have to give the psychosocial support to do counseling, and you can also help the person where he can get treatment, the path that he can get treatment. So as we here in Somalia, as we here in Somalia, especially by the we have a lot of people who are depressed and also stressed because there's a lot of challenge here on the war. There's a lot of war. You may see that a family, a whole family living in the same place, maybe save one person, other people died. That person will be taken stress and depression. So you have to cancel in these things. All these people brought by Allah in the world, and He's the one who are also taken back. So every soul will test a life with death. So also you have to be patient and take patient. So if you told the person and advise him every time and cancel him, he may think that he will take through and he will become okay. So I personally, as a psychosocial counselor, I always counsel the people. Thank you. That's what I want to say.
Thank you. Thank you so much, Hassan. Esther or Annalice, do you want to share a final comment and then we'll finish for today?
The comment is, I personally, I really appreciate the way we have, you have prepared the lessons and the way we are checking, because there's a lot of things that we have not learned before. We have learning right now. So we really appreciate the way you are sacrificing your time and doing every time effort to understand all of the things. We really appreciate, and we will be continue, and we really appreciate. We will not forget you in life, because we have experienced so many things that we have not known before.
Thank you, Hassan. Thank you so much.
Yeah, thank you too. Welcome.
I'll stop the recording for now. I think we will